Our session will be recorded, and we're looking forward to your engagement in this in today's discussion. Breast health by any means necessary. So I'm going to walk through the agenda. Breast health by any means necessary. So first, we're going to have our welcome. We're going to introduce to you our speakers. And then we're going to offer just a really quick some basic information on breast health. And then we will move into an open and what we hope will be a robust question and answer period. And then we will close and we will have summarizing remarks by our speakers. Okay. All right, Cheryl, if you, so we are pleased to welcome you. We're pleased to welcome each of you here, including our partners, the National Association of Negro Business and Professional Women's Clubs, Incorporated. Sherelle Carper, is the National President and CEO. Dr. Latanya Conley is the National First Vice President, and many of their members are represented here. And I thank you all, we thank you all for rising up and making your way into the IAWH Women's Wellness Lounge. Now that we're all here, we want this conversation to be robust, as I've mentioned, and to keep things lively. We'd like you to place your questions in the chat, as I've mentioned. Cheryl Thompson and I, will read them throughout the session. Some of you have already submitted questions, and we're going to cover those as well. And we thank you very much. During your registration, you submitted questions, and we've already captured those and also shared them with our speakers. And we will do our best to get them all answered. Cheryl?
Some really great and gripping questions, too. One thing I wanted to offer you, something I learned this week, and Janine and I just tested it out this morning. We were having so many technical issues. Up in the upper right-hand corner of your screen, if you're using a laptop or a desktop, you should see the word view, and there's a little icon next to it. So in order to cut down on some of the visual sensory overload, if you click on view and use the side-by-side speaker or the speaker option, that should cut down on some of the visual chaos you might see if you're overwhelmed by too many visual images. So what I'm going to do now is introduce our guest speakers that have joined us this morning. So first, let me introduce Deborah Rundles. Deborah Rundles is an oncology nurse navigator. She began her career as a licensed vocational nurse 1 year after graduating from high school in Fort Worth, Texas. After 5 years as an LVN, Deborah received a Bachelor of Science in Nursing from the University of Texas, Arlington. She completed her Master's of Science in Nursing with an emphasis in leadership from Grand Canyon University. Deborah has been a nurse for over 30 years, with 22 years of her nursing career working at Sarah Cannon Medical City Healthcare, where she provides exceptional care as an oncology navigator. Deborah has been married for 32 years and is a mother of 5 children and 2 grandchildren. Deborah currently resides in Arlington, Texas, and says, "I am a nurse with a ministry to help others through the occupation of nursing." We're also joined by Jeffrey Ray, Dr. Jeffrey Ray, a radiation oncologist who was born and raised in Sumter, South Carolina, and is the youngest of 3 boys, all of which attended and graduated from Howard University. HU. His mother taught Spanish and his father was a dentist. He attended Howard University for both undergrad and medical school. It was during his 3rd year of medical school that he decided to work at the National Cancer Institute, NCI, at the National Institutes of Health, NIH, with a focus in preclinical and translational research in the field of radiation oncology. Dr. Ray did his intern year in internal medicine and completed a postdoctoral fellowship at NCI and completed his residency training at Indiana University Hospital. Dr. Ray spent a year in private practice in Tampa, Florida, and 3 years at Sinai Hospital in Baltimore, Maryland. In 2019, he moved to Myrtle Beach, South Carolina, and is currently serving as the medical director of radiation oncology at Grand Strand Medical Center. In addition, Dr. Ray serves on the Radiation Oncology Executive Committee for the Sarah Cannon Institute. Dr. Ray says, "I am passionate about delivering the best care and to provide as much information and resource to my patients."
So we welcome Deborah, and we welcome Nurse Navigator Deborah and Dr. Ray, Jeff Ray. So breast health, by any means necessary. What does that statement mean to you? I'm going to ask that you please add that some ideas into the chat and get you into the habit of using the chat box. So breast health, by any means necessary. Can you find the chat and just in a few simple words, share with us what that means for you, and we'll talk about that a little bit later. As you're doing that, I want you to know that we're here as one body, a body of women on a mission to learn and ask questions so that we can advance our health and our wellness. As we continue to deal with the coronavirus crisis, other important health issues haven't gone away. Sometimes it feels that that's the only thing that we're focused on, but they haven't gone away. Our health and prevention of breast cancer, obesity, diabetes, high blood pressure, mental health issues, and following up on care recommendations, they make up the things that we must address. We come first. And if you could repeat that, I don't have to hear you. We come first. I come first. Change that to I come first. In order to achieve all that we have planned for our lives, we have to put ourselves first, our health first. So let's take a step back, or step forward actually, and talk about a few basics around breast health before we get into our questions and you hear from both our guests.
So we can start that conversation with a few baseline or a couple of baseline questions to help frame the discussion that we're going to have this morning. And I want to start from the very beginning with both our guests asking the question, what is the role of an oncology nurse navigator? And what is the role of a radiation oncologist in a woman's cancer journey?
Would you like for me to start?
Sure.
Okay.
Mm-hmm.
So basically, an oncology nurse navigator is typically a registered nurse who begins the process of evaluating the patient from the beginning of the diagnosis and in a specific cancer-related field. So each modality is designed to cover, in my case, I have covered breast cancer patients and gen oncology patients. So from the point of diagnosis through every treatment phase, there is a nurse navigator that is alongside a patient to make sure, I call it a concierge concept, meaning that if a patient is diagnosed initially, the physician gives the diagnosis and the nurse navigator makes sure that the patient has an understanding of the diagnosis and make sure that the patient understands, based on that diagnosis, what could possibly be the treatment plan. So as the patient begins with surgical intervention, chemotherapy, radiation, reconstruction, post-treatment follow-up and testing, the navigator creates touch points. And in the role of navigation, that touch point is always unique to the hospital system or corporation involved.
Mm-hmm.
And so as they go through the process, there is a nurse alongside. And the ultimate goal is to follow all the way from the very beginning, all the way through the modality to the point of completion of therapy.
That is truly a comprehensive role. Thank you. Thank you. And I think there will obviously be a lot of questions for you as you,
I know.
you know.
It sounds like there might be a bit of social working involved in that as well.
Yeah.
Yes, there is.
Thank you. And Dr.
Okay.
Okay, so radiation oncologist is, one part of the team that's involved with cancer care. Usually we work side by side with, the surgical oncologists, many other types of surgeons, as well as the medical oncologists, and as well as other doctors of the team. In regards to breast cancer, we work pretty much together with, our nursing navigators, the surgeons, as well as the medical oncologists, to come up with a plan and best supportive care for the patients. And so radiation, again, is just one part of it. It's a very big part when it comes to breast care. We also treat a lot of other disease sites, but for the most part, at some point, patients will either need radiation, in regards to their first initial treatments, or possibly down the line for other types of treatments in the case of, advanced disease or metastatic disease. And so we do come in at certain time points, but again, we're just part of the team that helps the patient along with everybody else, as well as the primary care doctors and other physicians and providers.
Mm-hmm.
Thank you.
If I can ask one more question, Janine, before I turn it back over to you. You
Sure.
just mentioned primary care. And so I'm curious, just from just a fresh patient, say I'm a new patient, I want to know how you as a specialist, Deborah, you as a navigator, how all of you tie into my primary care. Who is responsible for making sure that all of my care works together? I know you mentioned the word team, and I know about patient-centered medical home and teaming. How does all that work together? And is that a best practice for a patient?
Dr. Ray, would you like to start, or would you like from?
I can definitely start. So of course you want to get the primary, at first, an involvement with the care. In regards to survivalship, and we're going to get into some of these questions as well, but in regards to the cancer workup and diagnosis, the primary care doctor is critical, to getting the test and getting the workup done. Usually as a radiation oncologist, I kind of sit back and I pretty much know the answers. Usually when patients see me, by the time that they are in need of radiation or about to see me, their workup has pretty much already been done. Their mammograms have been done. They got the diagnosis of cancer. However, we try to initiate the treatment and plan prior to that, and so again, it depends on the system that you're in. I've worked in hospital systems where all breast cancer patients were presented prior to the initiation of treatment. I think most of the time the breast surgeon is the one that kind of initiates the breast cancer care. But again, the primary is involved with at least knowing what's going on, because at the end of the day, the primary is going to continue to follow, whether it's during the treatments or after the treatment. So keeping them afloat of what we're doing is critical to the not only breast cancer patients, but just pretty much all patients in general.
Yes, and to answer that question as part of the team as a nurse navigator, my leadership with the primary care is a multidisciplinary team approach, just as Dr. Ray said. So every person involved and every modality involved is so important. There is no way as a nurse navigator I could exist without Dr. Ray, because as I go through the channel, I might give the patient the information initially, but as the patient goes to his office, it's a sense of being at a relief because she understands, or he, in the case of breast health also, is that there is someone licensed that already has said, you're going to meet Dr. Ray. He is a really good guy. This is the plan. So if they sit before him and he says that the treatment exists of maybe 4 to 5 weeks, they're not in a shock. They've already heard that, and then that it helps build trust within the team, because as a team, Dr. Ray has his precision and things with radiology that and radiation care that as a nurse I am aware of, but as we drill down and go into detail, it creates a collaboration and multidisciplinary approach that gives the patient comfort that everybody's on the same page.
Great. Okay.
Thank you. Thank you for that. I have on the screen just a few basics of breast health, and I'm going to go through these really quickly, but this is just to help present sort of a framework of what we're dealing with, and I think it might help launch either additional questions or to allow us just to get right into these other questions that I know that you have for both Deborah Rundles and Jeff Ray. So to the far left is healthy habits, right? And you see there are a few bullets there: to eat 5 or more servings of fruits and vegetables each day. We hear this all the time, right? But I think as we continue our conversation, we'll understand why all of this is very important. To get regular exercise, maintain a healthy weight, limit alcohol intake to no more than 1 drink per day, and do not smoke, or to make many attempts to quit smoking until you're successful. Early detection. Now, early detection means finding the cancer before it spreads. Breast cancer cannot be prevented necessarily, except with some of those habits that we mentioned, but early detection provides the greatest possibility of successful treatment. By following these 3 steps, you will help increase the chance of detecting breast cancer early. And those are listed here. Breast self-awareness. So checking your breast on a monthly basis. If there's some lump thickening in or around near the breast area, under the arm, a change in the size or shape of the breast. I won't read all of them, and you see them on the screen. But also discharge or fluid from the nipple, to look and to know your body, more importantly, right? You should see your healthcare provider about any of these symptoms. Often these symptoms are not due to cancer, but if you notice any changes in your body, tell your healthcare provider immediately so that the problems can be diagnosed and treated. So immediately, again, putting ourselves first, not waiting, all right, by any means necessary, yes. The yearly physical and well woman exams. The well woman exam is a great opportunity for you to discuss with your healthcare provider any questions or concerns that you have regarding your breast health. For example, your doctor may help you determine the most appropriate personalized frequency for early detection. So in some cases, they may say that a woman should get a mammogram every 2 years. But in some cases, your doctor may recommend that you receive a mammogram every year. So ask the questions, come prepared with a notebook and questions that you've already developed for that conversation. A mammogram, we talk a lot about mammograms. Women ages 40 and older to get a mammogram each year. It helps to detect cancer and other problems before a lump enlarges, to detect by touch. It's an effective way to find breast cancer in early stages when treatment is usually the most successful. Safe, quick, and relatively painless. And I'm smiling.
That's debatable.
But it is amazing.
Yeah.
It's so improved over the years, and also with that technician's care and direction really helps to relieve any sense of being uncomfortable. Okay, so here we just have a few stats that I'd like to share with you around the burden of cancer in the United States. Breast cancer is one of the most common kinds of cancer in women. About 1 in 8 women in the United States will get breast cancer in their lifetime. By race, white women and Black women have about the same rate at around 12%. Asian, Pacific Islander, and Hispanic women have about the same rate as each other at about 9%. And then American Indian women are at the least risk at about 7%. Black women and white women get breast cancer at about the same rate, but Black women die from breast cancer at a higher rate than white women. And we will ask the question, if you haven't already put it into your chat, why is that the case? And we've talked about getting our mammograms. We've talked about staying on top of our appointments, making the appointment, but keeping the appointment as well. And some of those are some of the reasons. But deaths from breast cancer are going down among both Black and white women, that we should be applauding right now, especially among younger Black women. But breast cancer death rates are 40% higher among Black women than white women. So of all women, although the rates are going down, African-American women, or Black women rather, our death rates are higher. Breast cancer was more likely to be found at an earlier stage among white women than among Black women. We talked about mammograms and keeping our appointment. The good news is that mammograms can help find breast cancer early. That's the great news, before it spreads to other parts of the body. Most women can survive breast cancer if it's found and treated early. So that's my my PSA for the day and public service announcement. And now we're going to get into the discussion. And so there's all coffee and tea there, but I bet some of you are sipping on water, or I hope enjoying your breakfast this morning. So, but right now I'm going to stop sharing my screen so that we can get into the conversation. And Cheryl, do you have some additional questions you'd like to start out with?
Sure. Let's just jump right into it. One of the words that did come up, and we often hear about it on television and commercials, and this word metastatic is being thrown around. And it would be really helpful for folks if you could break that down. What does that mean? What does metastatic cancer mean? And is there anything special that in terms of prevention that would help prevent metastatic cancer, or is everything still genetic? And either one of you can, or both of you can address that question. A good definition of metastatic cancer and how to avoid it.
Well, I will answer, and remember, always when I answer, I'm always really working hard to stay on the most, how can I say it, easy to say form. So Dr. Ray will give the more technical aspect, and I will give the easiest layout and form. When you look at metastatic, I explain to patients, you have an origin or a place where it starts. So whatever your birth home is your origin. Once you move from your birth home and you begin to travel through the state or country, you create a metastatic point in that each place that you go to, a part of you is being deposited there. And knowing that I'm from the South, it's very hard for me to go up north without some of the local Southern language, so I will say that. But in the body, you have an origin of a disease such as cancer, such as breast. And when they do a biopsy and get a report, they will tell you breast cancer. When it becomes metastatic is when that cancer has left the home of the breast and now it's transplanted somewhere else in the body. And certain cancers, such as breast cancer, typically the literature and the research says when breast cancer moves, it basically has two primary areas that we're concerned with, and typically that is the bone and the brain. But that's not exclusive to those areas. So now, Dr. Ray, you can go into the eloquent, more official and technical language.
And don't forget to unmute yourself.
No, that was good. You know, and just to kind of, I guess, give a broad picture, you know, we do have circulating tumor cells in our body. And you hear the immune system and immunology, which is the study of the immune system. And basically you have T cells, or cells that kind of go around and find pretty much anything that's foreign to the body, or cancers, bacteria, those types of things. And so a lot of times we do have metastatic cells that are going in through our body because of tumor cells. They're generating these populations of abnormal cells. And so that's what cancer is, an abnormal cell. And so sometimes what happens is these abnormal cancer cells are able to survive on their own. And we kind of generally think that they're, in the case of breast cancer, these cells are coming from the breast origin, and then they travel. And most of the time they go through the lymph nodes, which is an area of deposit that, you know, your body gets rid of different types of things. But also your blood is another way that cancer cells can travel. And so what happens is these cells leave that origin, and then they deposit, you know, as you know, just as you said, in the bone or in the spinal cord or the brain, you know, and so then that's when we call metastatic disease. And so it just means that it went from point A to somewhere else in the body, and now it's clinically detected or radiographically detected. And so just kind of going into a little bit more detail, you can always have oligometastatic disease, which is a very small amount of disease. You can have like 1 or 2 areas in the body that are detected. We treat those a little bit more aggressively. And then you can have multifocal disease, which is systemic, or, you know, when it spreads to multiple areas and you see multiple lesions. And we typically don't treat that as aggressive with local types of treatments like surgery or radiation, but we do, you know, continue to do things like chemotherapy and systemic therapy. So just metastatic disease, again, overall, just means that, you know, it went from point A and now is at point B in some other organ or system in the body.
Great. Great answer. As Janine said earlier, please use the chat because as we have this discussion, I'm sure questions will be coming to mind. And someone did use the chat. Question is about healthy weight. How do I know what an individual healthy weight is? And then what is an ideal weight, and how does weight play into breast cancer?
When you look at weight, there is what we call a BMI, which is a body mass index. And based on your height and weight, there is a range that is acceptable for weight. And everyone is calculated based on those two, your height, and they say based on your height, you should weigh a certain percentage. When we look at weight and cancer, in many ways that is seen as a modifiable, preventable target or goal for someone for preventing cancer. And that's not exclusive, because there are many people that are in the ideal body weight that still develop cancer. As Dr. Ray said, cancer cells are basically, I put cancer cells as being invaders or squatters in the body, and they're looking for opportunities to advance. And so when your body weight is not an acceptable body weight, it is the whole body's system and structure is thrown out of balance. And so you're predisposed to other things that are related to being your weight not being within the acceptable range, such as diabetes, hypertension, different forms of disease processes that occur. And so once the body is focusing on dealing with high blood sugar or high blood pressure, then the cancer cells can actually kind of take advantage to and I explain to my patients, kind of say, well, since you're busy here, let's keep reproducing and modifying, because cancer cells modify at a rapid rate. So if you have rapidly growing cancer cells and then you have a rapidly changing body and increasing of weight, then it's the stress and burden that you have on your whole body system. So I explain to people that not being in the ideal BMI, body mass index, has a greater impact for our health, not just based on cancer, but our overall health.
Great.
Wow, thank you. I'm glad we're recording this session, because I may take that word for word and use bits and pieces as we move forward in the discussion around just not just breast health, as you've made it clear, and Dr. Ray has made clear how important it is for us just to be healthy in general because of the impact that it can have on our bodies. And I know we know that, but that was such a great question. I see a question from the National Association of Negro Business and Professional Women's Clubs Incorporated. They have a special program that focuses on triple negative breast cancer. And the question is there a different conversation that we need to have with our doctors and nurses as it relates to triple negative, or being cautious, or what questions should we be asking?
I can take this one. So there is definitely more, I guess, more aggressive forms of breast cancer. And triple negative is what we are seeing as more and more aggressive. And what that means is that we look at hormone receptors, because breast cancer is a hormone-driven type of cancer, so is prostate cancer. But when we're able to target something, that means we have a drug that can target those receptors. And another receptor is something called a HER2 receptor, which is the human epidermal growth factor receptor. And that's another targeted receptor, and we have drugs for that as well too. The problem with triple negative disease is that now you have no receptors that can be targeted with some type of systemic therapy, whether it's hormone or Herceptin or something like that. So typically with anybody who's triple negative, and it doesn't matter the size of the cancer, we used to, look at size and pathology and look under a microscope to say this cancer is aggressive. But now we're looking at these biological markers. And so even patients who have a small triple negative disease, we still consider that very high risk. And so most, pretty much all of these patients do need some type of chemotherapy or something like that as part of their treatment workup and plan. So it just means that we haven't really found any good receptors for them to target. So these patients usually are, and again, unfortunately, we're seeing them in a lot of minorities as well too. And so I think that's another reason why, Black women have more aggressive breast cancer than other, races. So, that's something that I do think we need to be more aggressive towards. And so if you do find someone with triple negative disease, like I said, most of the time we do have to kind of treat these women a little bit more aggressively, regardless of the size of the cancer.
Wow.
I would like to add to that, because that's completely, Dr. Ray is spot on with that. The way I discuss triple negative is I'm a tenured nurse, mature. I'm not going to use any other word other than that. And 30 years ago, whenever a woman was seen to be triple negative, they automatically said she was African American. Mm-hmm. And so triple negative was seen at a higher proportion in African Americans. Now today, triple negative is across the spectrum with every race of women. And when I have a patient that explains triple negative, that's what we call the prognostic panel. And it begins with estrogen, progesterone, and then the HER2. And Dr. Ray explained HER2. And basically, I explain to women, if you're triple negative, it's like a fire. So if we have a fire in a basket that is wood, we know to put water on it. If we have a fire in a basket that's oil, it's that baking soda. You know, I'm from the South, so you throw that baking soda. If it's electrical, you pull it from the source or the electricity. The problem with triple negative is you don't have a pinpoint or a specific chemotherapy. So women with triple negative breast cancer get the highest level of chemotherapy because of that small chance for triple negative of being metastatic. And whether it's metastatic in a small portion, which Dr. Ray, that's especially important for our radiation oncologists with those triple negative patients. We look at that modality of radiation oncology at a whole different perspective. And Dr. Ray is looking at that because is it a small area we're looking at or is it a vast area? So with triple negative, how do we put out that fire? Because if we know you're estrogen positive, we look at a different chemotherapy subset. And then we look at, after that point, you being on a, as women call it, my hormone blocker pill for estrogen. Progesterone, you look at a different modality. HER2 positive is a different. But when you're negative, the medical oncologist then has a look at his basket and say, this individual woman, what is her health risk? What is her past cancer history? And based on that, triple negative is always a more aggressive cancer and a more aggressive treatment.
Oh, thank you. Thank you. Thank you. And if there's additional questions that anyone has, please drop them into the chat. Thank you very much, Dr. Ray and the nurse oncologist.
I know, these are really great answers. They're just
Wow.
so easily understood the way that you're breaking things down. So thank you.
And as I'm scanning through, I want to make sure that I get, let's see, right. Okay.
Janine, can I ask a question? Let me ask a question that is not necessarily cancer specific, but leans more towards just health in general. So when we all go for, or we should all be going for mammograms, is there a way that you can help us this morning have more intelligent conversations with our health providers? What is it that you are looking for when you are screening a woman with a mammogram? And then overall, what is it that we can do for breast health? How should we be taking care of our breasts so that we have better outcomes?
Well, I would say, and definitely Dr. Ray, I'm just talking on having the tool and going through this process. I explain to every woman that once you realize you have breast, you begin to check breast. So when we have a talk with a young lady that she's getting her first bra, we need to start having that same talk to say, now you really need to be aware of the changes. So we have it written as at the age of 40 began mammograms, but there is a higher number of women under that age diagnosed with breast cancer. So we're missing a group of women because these women feel like I'm not over 40, so I can't have breast cancer. Well, not only in breast cancer, but breast health, there are different, and Dr. Ray can attest to this, there are different things in breast that are benign, which we consider good, that can occur in breast tissue at any point. And so I say, number one, every woman needs to have their notebook, because we know what questions are going to be asked every time we go to the doctor. From the time you're a woman and you first go until the time of, good Lord saying this time is gone, a doctor's going to look at you and ask you when did you start your menstrual cycle. They're going to ask you medications. They're going to ask you that even if you can't have children, if you go in, can you be pregnant? Are you having issues? So keep that notebook. And keep that notebook, and because you can think you had a mammogram a year ago and it was 2 years ago, be prepared to know that mammograms have changed. Mammograms now, the technology is with 3D, and mammograms will create some discomfort for women, but as a whole, know when your cycle is, when you're getting your mammogram. And women say, well, I'm not worried about my cycle. But remember, your body's still hormonally. There are certain times that it's a tenderness or it's a little bit more difficult to have a mammogram. So be aware of that. But the key is, for every woman that is on this call, any man that's on this call, we know that if you have children or a loved one, you can see them. And they can walk into the room. And I use this analogy with every patient. If you have a child, a husband, a loved one, they come in the room and you look at them and say, what's wrong with you? Have you ate today? What's going on? But you can't see yourself. So also lean to whoever that person is in your life that is your accountability partner, your loved one, and make sure they're taking a look also. And I'm going to be candid, as I am. I'm married, so I always say that my physicians and my husband's, Lord, no, my husband, my husband, don't shake your head, Dr. Ray, only run.
No judgment.
But, okay, so my husband and my physicians, I get my regular checkups. So if there's something that I am not noticing, I'm looking to them to speak up. And one of the controversial things is they're telling, this time went where they told women don't do self-breast exams. The reason they said that is because you can't always feel a lump, but there are some breast changes that are visible and you still are able to notice a difference. So I tell people, if it changes, speak up. Don't take, and not only your breast, but your whole body. If it changes, take that time to make your appointment. Take that time to take care of you. And typically what happens is once a woman is diagnosed with breast cancer, they get an entourage of physicians. Dr. Ray has patients that he has been with, and it's a yearly check now. And he sees them and they say, well, why do I come every year? And I said, because this was the person on your team that began with you. He is making a check to evaluate. So when my women say, well, I don't have to see a Dr. Ray anymore. Yes, you do. But keep that notebook, because as we all mature, a year ago could be 5 years ago. And that 5 years can make a difference between an early stage of any disease and a latter stage. So every woman, get you a spiral notebook, get you something, put some pockets, holes in there, look at lab work. When you go in, it's like buying a car. You tell your physician the updates, and then he does analysis from there, and it makes it a better, more cohesive visit. It makes you feel a takeaway that all of your questions and concerns were answered.
Great.
Thank you. Thank you, Dr. Ray says, and I agree. And Dr. Ray, and this is also to Deborah, who recommends and when is it determined and decided that radiation is needed, and also the same question to when I can expect a navigator as a best practice. So can we start with radiation? When is it decided, and what cases will women come to you?
Right. I feel like I'm on a debate stage because I want to go back to one topic. I think it's interesting because, and this is going to be real quick. I think women, and actually in general, we should all be aggressive with. And when I mean aggressive, I mean, and I've seen this before, where you go to a doctor, and it happens to me. A doctor sees me and just assumes that, I don't know what I'm talking about, or, they don't need this test done or this study. And unfortunately, I think with minorities, we're kind of dismissed, at the time where we see it, the doctor, the provider. And, you know, I've seen patients of all ages and all races, all sexes who have cancer, you know, and cancer does not care. It's kind of like the coronavirus. It does not, say who is going to get it. Basically anybody can, you know. So if you feel something's wrong or feel some changes in your body, you know, definitely speak up about it and get tested and get the imaging studies done. So that was just one thing I just wanted to kind of touch base on. So who determines or what part of things? Again, you know, with cancer, it all depends on the stage and the workup. Kind of, you know, when are you seen or when are you diagnosed? You know, sometimes unfortunately it's too late to kind of say, you know, we're going to do something that is for cure or you know, something that we can manage this cancer in a way that we are going for that. You know, sometimes it's just for palliation and that type of thing. But for the most part, we do have a certain guidelines or certain set of ways of dealing with patients and managing their care. And I would say majority of oncologists, you know, radiation oncologists, surgical oncologists, medical oncologists, we all go by these guidelines. I mean, of course, there's going to be some patients who are, you know, outside of that or need special care, and whether they can't tolerate chemo or can't tolerate surgery or radiation, we may have to do something else. But at the same time, you can kind of work with what you have. So, you know, and again, and nurse navigator is important because, again, they find at that point to say, hey, you know what, this patient needs this done and needs to see by this doctor. And so, you know, we all kind of work within certain parameters. And I think just having everybody involved, you know, and again, sometimes patients are not candidates for a certain type of treatment, but it's good to know because, again, sometimes other doctors, you know, we get blindsided. We only see, or, you know, we only focus on what we do for the most part. And sometimes it's good to know that, you know, this patient may not be a candidate for this reason, or maybe a candidate for something else, you know. So we're always learning, you know.
Thank you.
What I will add to that is Dr. Ray said guidelines, and typically every woman write these initials down. It's called NCCN, and it is a National Comprehensive Cancer Network. And so Dr. Ray, as he's doing his analysis, always you can say, and I never say this in the medical world, there's always something new or different that you need the expertise of someone else to say, how was your typical treatment? That NCCN guidelines is in the cancer world, oncology realm, is the guidelines that every reputable physician is following. And so that NCCN guideline is what we go by, but understand we're also evaluating the patient. So Dr. Ray has a guideline of when he's beginning radiation of what dose he is beginning with for a patient. But if there is a change, ladies, and if there's a gentleman on listening, if there is a change, then Dr. Ray will adjust for that patient. And so as a navigator, and I think one of the questions was, how does navigation go into play? Navigation is basically set through individualized facilities. So navigation is a new realm of nursing and relatively new, in that along the way as a nurse, we were always navigators, and nurses are always navigators, but it's the concept of now when they leave the hospital, who is making sure the continuum of care is occurring. And in navigation, you have navigators that are registered nurses, and then you have lay navigators who, in some physician offices, they have a navigator. So once you're diagnosed as a patient, you can ask about navigation. In some cases, there is a navigator that is set up in the hospital, in physician offices, and then in corporations or companies, they have navigation. And so when you're looking at the guidelines and the navigation and the process, you should have a care plan in front of you that reads, this is where we're starting from. This is the estimated time of when we're starting. But understand we're individual. So I always explain to ladies, if you have in mind you're getting chemotherapy every 3 weeks, don't hold to that, because we also have to evaluate. So if a doctor says, no, not this week, and you have a cruise planned for next year at this time, you should hold that money. Not saying you can't go on that cruise, but understand your health is being determined each stage of the way. And Dr. Ray is not giving himself the overall credit in that he is brought in as a specialist from, you have the primary care, you have the medical oncologist, you have different modalities along the way, and they say, we're going to send you for a consultation with Dr. Ray. And he's going to sit down with the patient way before radiation starts and ask questions. And then he's going to propose, this is the treatment plan I have in front of you. But then he's going to have people on the team that say, these are the things to prepare you. Each time you come, we're going to ask you the same question. Just as I tell patients, answer it, because that's following through. So there are certain pathways and certain guides that Dr. Ray, his expertise in his area, sometimes we look at, are we noticing a group of women that are occurring with this type of cancer in this area, or is it the whole population? Is there something that is triggered more in one area? Is there something, such as genetic, that is showing up that Dr. Ray is saying, oh, did I take care of your cousin or your mother? Then he starts to look, and he might, as a radiation oncologist, go back to medical oncologist and say, here, I seem to have a family of people. Have you tested or checked someone else? So Dr. Ray is, even as he completes, as people say, well, I'm done with 4 weeks of radiation, he's sending a synopsis of what he's done in his recommendation. And that recommendation changes to, is this patient ending treatment, or are we looking at another modality? Because his expertise also includes doing a CT scan to evaluate, looking at all of the prior information. So it's a continuum. So we believe that cancer is going to play fairly, and it does not. Cancer is continually migrating and changing. I explain it as a parasite, right? So as it's continually changing, Dr. Ray is continually modulating and changing what he needs to, and then he has regulations that he abides by, and is what is acceptable and being safe to the patient and treating the patient also.
Thank you. I want to go back to triple negative. There's someone in someone wrote in the chat that they were diagnosed with triple negative breast cancer, and she had a lumpectomy, right? She had radiation, and she was told that she did not need chemotherapy. So just wondering whether or not, if there should have been a more aggressive treatment, and I understand you're not being her physician or her clinician, you can't just state, but if you could just talk to it in a way that perhaps will provide some answers. Yeah.
Yeah. And again, when we first diagnosed patients, years ago, and this is not just breast cancer, but a lot of different cancers, we used to look under the microscope, and that was to determine how aggressive cancers were or are. Of course, things are important like size, number of lymph nodes, lymphovascular disease. I mean, all these things we still focus on, but in breast cancer, we're starting to kind of change that a little bit more and start focusing on those receptors like the triple negative, ER/PR positive, HER2. And it's starting to become more, I would say, more practice to start using chemotherapy in those types of patients with the localized treatment is still the same. I mean, we can still do lumpectomies. You don't necessarily have to do like a mastectomy or anything like that. If it's localized disease, you still get the radiation, but for the most part, we do initiate the chemotherapy. And this hasn't really been practiced. Maybe in the last 5 years, we started doing this more and more, because again, we're starting to change, as Deborah mentioned, our approach to cancers. Again, it used to be size and pathology. What you saw was how aggressive it is. It's not that anymore. We're looking at genes. We're looking at DNA. We're looking at, just looking at how cancer biologically is changing. And I think that's why things are more important with, systemic therapy, these immunotherapy drugs, and to be honest with you, I mean, the way we're treating it has gotten better, just because more so than anything else, the systemic therapies have gotten better. They're more targeted now, and we're able to kind of, again, focus the treatments based on the biology and not necessarily on the pathology that we used to do.
Thank you.
I hope that answers.
Yep, I'm hoping that helps a bit for the person that wrote, that added that to the chat.
Can I add to that?
Absolutely.
Women have the misperception sometimes that if they have cancer, the surgical form of treatment is mastectomy. And it is interesting, in Texas, for some reason, we have a higher rate of women having mastectomies. That NCCN guideline is a pathway of saying, if you've had a lumpectomy, that doesn't mean that there is a problem with that lumpectomy. It depends on the stage and the grade of the cancer at the time. So having surgery is an intervention. It is a treatment. And so if you're triple negative, and based on being triple negative and the size and the grade and the stage of that cancer, a lumpectomy, early stage, might be all the treatment you need. And then the person that typed that in, I am sure she is still following up with her medical oncologist, probably a yearly visit with her breast surgeon, and still having, if you've had a lumpectomy, you're still doing mammograms or diagnostic testing. And so because you had a lumpectomy and you're triple negative doesn't mean that we go completely to the aggressive point. That means that the probability with triple negative is that you're being evaluated on a more stringent level. So there are women that say, I had a mastectomy because I want to be done with it. But understand, cancer cells don't say, oh, mastectomy, you're done with it. There's still evaluation. And if you have breast tissue, sometimes that plan of care for you with the lumpectomy and triple negative is, are we looking at different modalities? Are we looking at doing a mammogram and 6 months later following up maybe with the breast MRI? Or we're looking at different treatment plans? So there is more to a cancer diagnosis than just a cancer diagnosis. If you have a very small evaluated cancer cell and all of the tissue around that is healthy, there are plenty of triple negative women that have a lumpectomy, have no other follow-up past that, and meaning no other intervention other than it being evaluated, and live very healthy, fulfilled years. So, and when I say to that is the person with the lumpectomy, was this person a person that was yearly getting her mammograms, yearly noticing a difference, yearly following up? Early stages and grades really equate with a better outcome. And so the biggest takeaway from this morning is, if you find it early, your outcomes are a lot better, because it's the difference between putting out a small fire and putting out a monstrous fire. Can you put a top on it, evaluate it, and go from that point? So there is not a wrong for that person that had a lumpectomy, because her treatment was individualized.
Oh, thank you very much. And thank you both for addressing that question. And many of you may have had a similar question, particularly around lumpectomies and treatment. And it's very clear that the treatments are different. Timing is different. And also your regular visits to your, and continued regular visits to your oncologist and oncology team if you're referred. Cheryl, do you have another question?
I could take another question that's in the chat. The question reads, I have had multiple biopsies and developed keloids. those areas are extremely sensitive and often painful, what options do I have?
I can take this one. Yeah, some patients or people are, you know, more prone to developing keloids. You know, and I've seen patients who, you know, sometimes they can just scratch themselves and develop one, unfortunately. You know, so you know, usually the only option really, I mean, other than, I mean, the biopsies were, I guess, were necessary to evaluate for something. But for the keloids, you really can't prevent them. You can treat them. You know, you can do surgery. Sometimes, you know, it sounds like if you're very prone to having keloids, you know, you can do radiation after it. It's a pretty relatively low dose of radiation. You know, we typically try not to, but I've had to treat patients with radiation for keloids. You know, but I think the biopsy is more important. I mean, I hate to say, you know, compared to everything else, but they're trying to evaluate something that seems to be, you know, a malignancy or something that's very suspicious for one. I just think they just got to kind of have to take it and, you know, treat it surgically if you can. You know, it's just one of those things where unfortunately it seems like it's just something that may have to, you know, be evaluated, you know, maybe not a biopsy, but maybe ultrasounds or those types of things to kind of not be as invasive.
Thank you.
So Dr. Ray, can you explain what is a keloid and why do they develop?
So keloids are just hyperactive cells. They're benign, so, you know, they're not, you know, any type of malignancy or anything. They're just basically the cells are just responding to some insult or injury. Like I said, some patients develop it, you know, you can develop it if you're getting, you know, I see a lot of times with people who get, you know, earrings and they develop keloids in the back. But, you know, you see it anywhere in the body. And again, it's, you know, I see it more with African Americans than I do with any other race. And so it's just, you know, the biological patterns and why it occurs, I'm not 100% sure why, but I just know I see it a lot more in African Americans.
It's interesting you mentioned African Americans because a question that we received in the chat, but also in, thank you for that, Dr. Ray, in advance by some of the participants is about breast density.
Yeah, I was going to bring that up.
Yeah. Is there, so can we talk about breast density, what it means? And one of the questions in particular are African American women or Black women at a higher rate, you know, are we known to have a higher rate of
Higher breast density.
So please, either can speak at whatever time.
I will go back to, and I'm going to proceed with that. Ladies, if you know you have a potential for keloids, you need to have that as your history, because there are very skilled breast surgeons that are aware of keloids, so that makes a difference on their incisions also. So that needs to be one of the questions when they're asking any skin issues, that you put a keloid in place. Because being aware of that keloid is the difference between thinking you're having a post-surgical issue as opposed to knowing that your skin tissue keloids. So you want to make sure your surgeons know that and aware, and even the anesthesiologist, because that's, if you're going in a surgical procedure, that anesthesiologist is the extra eyes and able to speak during your procedures to make a difference. Going to the breast density, and I'm going to let Dr. Ray explain, but I'm going to start with my analogy because I'm simple, okay? And I explain to people, when you're looking at breast density, I have not seen a bigger correlation in my practice between women of certain races, but the way I had to understand breast density is when you're traveling along a road and you see all of these trees, and you just see the trees. So you don't know behind the trees somebody's living there, there's animals there, because all you see are the trees. When you're looking at breast density, when they do a mammogram, all they see are the trees, ladies. They see a fog where they can't see past that through a mammogram. A mammogram is a technique that picks up breast tissue at a certain point. When you have breast density, it is evaluated in stages. And based on that when you get the mammogram and the doctor saying you have dense breasts, they have stages, and they're usually their recommendation to your provider that you're sending your mammogram results to is, let's follow up with the ultrasound, because the ultrasound now is a different modality that can see through the density at a different area. So breast density doesn't mean you increase your chance for breast cancer. It means you increase your chance that those trees are blocking what's behind that, or that breast tissue. So there was a really interested Hinda Law, so you can write this down, Hinda Law, and her name was Hinda, and she was having mammograms, and in the process of the mammograms, they seemed to appear okay, that we didn't have that standard in place. And later it was evaluated, it was seen that she had breast cancer. So the question was, should we go back to the provider or the person that did the mammogram? And then it was, well, in that perception of the person, not right or wrong, it didn't show on the mammogram that there was anything unusual. The next step would have been to do an ultrasound. But let me give the key point to you, everyone here. We're still regulated by insurance companies. So if a doctor says you have dense breast, and before this Hinda Law, you have dense breast, and you say, well, I'm gonna do an ultrasound, and your insurance company say, well, you go ahead and do it, because you're gonna pay maybe $400 for that, and then a provider to read it, and then somebody who's on a fixed income, or now you don't have to be on a fixed income, but your budget says, I don't have $800 to spend on a ultrasound to come back. I'll wait till next year. So what was happening in that year, even with breast dense, we were having advanced breast cancers, because what was occurring is, instead of being able to evaluate, let's do an ultrasound, let's see, oh, we have an early stage, insurance companies say no, then that person says, you know, I got to eat this month, I got to pay bills, I'm not going to pay for it. And then it was not until that law that it was mandated. If you have breast dense and breasts that are dense, then there is a level of insurance companies have to come back and say the next step is, let's do an ultrasound. So the breast density, why people are saying I have dense breast, that just means you evaluate at a different level and at a different frequency.
Thank you. Thank you. Thank you. Thank you. I'm going to keep going with some of these questions because I know time is moving along. There's a question about genetic testing. Mainly, the question is, you know, we hear about genetic testing, but how accurate is it? And Dr. Ray, you spoke to how helpful genetic testing can be in, you know, with diagnosis and so forth. Can you talk a little bit about, I guess, accuracy?
Right. So it can be accurate depending on what we're looking for. So we do know for sure that there are certain types of genetics, BRCA1, BRCA2, that are found in patients who have a significant family history of developing breast cancers and ovarian cancers. And with those patients, you probably, you know, either read about or heard, you know, they get the prophylactic bilateral mastectomies, you know, so because they're more prone to developing breast cancer and more prone to the family members developing breast cancers. But we're also looking at other genetic profiles. And now the accuracy of those, I'm not too sure of. I mean, we are starting to see these variations. And again, with all cancers, that's pretty much what they do. They kind of change their DNA. So you're going to see some mutations or some forms of cancers that are not like normal cells. And some of these variants are being looked at. And it kind of determines also why patients do get certain types of treatments, you know, whether, you know, again, systemic therapy types of treatments based on that. We have something called an oncotype, where we look at the cancer and look at its genetic profile. And then those patients are put at a risk, either low risk, intermediate risk, or high risk, to determine if they're going to need chemotherapy or not. And again, these are just factors that we're looking into. And again, you know, with cancers, because we're looking more at DNA profiling it, we're starting to see more genetics involved in how we treat patients. And so going back to genetics and family history is very important. I mean, we all know that's kind of what determines these cancers. What's important is still being figured out or being assessed. Like, you can have all these tests done and you see them, but we actually have to look back, and it takes years of treatment. It takes years of following patients to kind of look at and see which patients were, had a more aggressive variant versus other patients. But we do know that there are some that are more aggressive than others.
Thank you. Thank you.
To add to that, just on one of the questions I ask is, I'm being asked on that, is that when you're looking at a genetic test, as Dr. Ray said, typically you're looking at BRCA, but there are other genetic testing that is done, such as Lynch syndrome, Cowden's. So usually when a lady who goes in and has a genetic test, they will get a result that says positive, negative, or uncertain. And so when a lady comes and said, what does uncertain mean? And I say, there's probably something genetic going on, but we might not have discovered that gene yet. So 30 years ago, we did not discuss BRCA. 30 years ago, we knew that there would be possibly a group of women that said, my grandmother had cancer, my mother had cancer, my aunt has cancer, but the BRCA gene wasn't evaluated that way. And in one of the landmark decisions that our Supreme Court and our judges did, once someone discovered it, someone said, now we want a trademark and we want to hold to that. And then there was a decision that said, no, you cannot trademark genetic testing and genes that way. So just because a woman says my BRCA test is negative, and you look at her family history and it says aunt, cousin, every female, that doesn't mean that there's not a genetic correlation. That means that our research has not caught up to that gene yet.
Got it.
So if you come across that and you know that every female in your family has that predisposition, but BRCA is negative, that doesn't mean if you have a daughter, you want to look back and say, and this is a question I always go back, if you have your mother diagnosed and an aunt diagnosed at 50, at 40, you need to be diligent. You need to be 10 years back. If it's 40, it was seen at 30, you want to look at that. So you really want to start with breast health 10 years before that.
Mm-hmm. Mm-hmm.
Because that 10 years is that evaluation that can occur quicker and at a more expedient level.
Deborah, that's interesting, because this is starting to tie into another question that we see both in the chat, but also in earlier questions for people who registered around African-American women in particular, but women in general, but specifically African-American women. We started out with some statistics that African-American women die at a higher rate, right? Now we're talking about genetic testing and perhaps sharing our genetic testing information as well with other family members, or sharing our diagnosis maybe with other family members. But can both you and Dr. Ray speak to the reasons why African-American women are dying at a higher rate?
I'm going to go back to what Dr. Ray said. He is a very established, renowned radiation oncologist. When he walks into the room, he is seen as an African-American or a Black man. Based on your treatment from your provider is how open you are to have that conversation. So if somebody perceives you as being less than, you don't have that open dialogue with your provider. And thus, not only not having that dialogue, that relationship. And so typically, as we go through our family tree and go back, if we had a family member die of cancer, there was a point they didn't even put cancer or anything in there. They would say they died of a heart attack or something else. And cancer was seen as something that a person, because they were bad, developed. So great-great-great-grandmother that passed away of cancer, nobody's going to talk about it, because that meant, what did she do to develop cancer? And that's that stigma that goes with cancer. And so because that stigma is there, that rate and our mistrust, I mean, I could say one thing and Tuskegee and the whole experiment in that. That is our mistrust as a people of color, right? But that mistrust as a navigator, I see of people of Asian and of all the people of color, right? Because we don't have a trust for our providers. And until that dialogue, until we get more Dr. Rays in front of us, you know, because sometimes for me, for a patient is explaining, and especially if I have a woman that is not really trusting of the healthcare, and I would say to them, well, you're going to see Dr. Ray. I believe you will like them. And they don't want to come out and say, well, if he's a white doctor, then I don't want him. I mean, that's just how frank people talk. And I'm like, well, Dr. Ray is, you know, he's African-American and he has the credentials. And so you have to understand that is our mistrust. And so that increases, you know, our rate of our mistrust and distrust and our lack of coming to the table and feeling confident to explain. As Dr. Ray said, he can come in and say, well, my arm hurt, and the doctor who is not aware of he's a physician might talk down to him until Dr. Ray says, well, I've evaluated. And then it's like, well, how are you evaluated? And then when he goes on, the perception from that provider changes.
Mm-hmm. Yes, thank you.
And so we've got to change from the beginning that way.
So true.
Dr. Ray says, yes, so true. And thank you, because you addressed it at the beginning of this conversation, but we see it's coming up in the chat as well. There's a number of questions. We're at 9:58, believe it or not, and we know that we started and opened the doors 5 minutes late, and you all have given such a wealth of information. Would you be willing to spend another 5-7 minutes with us?
Sure.
Thank you. We have a few more questions, and women, and if there's women and men that are in the lounge, please hang out with us a little bit longer. More questions, and I'm also getting responses from women that, you know, that we must ask questions and speak up, and they realize through this conversation, you know, learning a lot through the conversation and others. So I just want to keep going.
If I can ask a quick question that does tie into what you've just been talking about, Deborah, just the flip side of that. So one of the questions that came in during registration was the acknowledgement of barriers to our own care because of that stigma that you talked about and that embarrassment of talking about symptoms with our healthcare provider, or the fear of getting a bad diagnosis or a fear of what cancer treatment will be, or even having our partners abandon us if we're diagnosed with cancer. Can you speak to that and how just sort of helping us shift our mindset so that we are in the position of taking care of ourselves first and not being caught up with stigma, et cetera?
I'm glad you asked that one. Thank you.
Well, so this is what I tell someone. From the point that you make a conscious decision for a health plan, you treat that health plan the same way you would do your phone bill. So if I pick up my phone and it ain't working, I'm calling the phone company, and you're going to get me a dial tone one way or the other, right? Because I paid for a service. If you go in that thought process of, once you're set with a physician and that physician is not acceptable, you're not being heard, then you go back to the insurance company and say, well, who's next? Who's next, right? So we have to learn to not accept that that's the way it is. We have to learn that as a navigator, still in this day, it breaks my heart that women walk into the emergency room. The first question is, what is wrong? And they say they have breast cancer. And Dr. Ray has seen this. Literally, they open their shirt and they have a big mass. And why? 2 reasons. Because they didn't have time to get it followed up, or I am told God will take care of it. And I'm going to say this, and I apologize, this is just me. God has providers that will help you take care of it.
That's right.
So because of that mistrust, we use our emergency rooms as our physician offices. Once we change that thought process to use our physicians, we decrease our ER visits, because then you pick up the phone and you say, Dr. Ray, I just had radiation. I'm noticing a skin change. And Dr. Ray says, let's make an appointment for you to come in a day before your radiation to evaluate. That way, you're paying maybe a $10, $20 copay, as opposed to walking into the ER, somebody don't know you, laying there in the bed, evaluating you. Now you have a bill for $1,000. And then Dr. Ray has no idea because you picked a hospital that he can't even check into and evaluate.
Mm.
But Dr. Ray, because he is seeing a patient for 4 or 5 weeks, and every day this person is coming in, when you miss that visit, his nurse or his other providers and clinicians are saying, Dr. Ray, they didn't show up. They make a call. You've missed a treatment. What is going on? And you have someone watching you. Actually, once a person is diagnosed, more than likely, that person changes their whole healthcare concept and understanding it's a team approach.
Mm-hmm.
Thank you. You all, I wish you could see the chat, but it's on fire. Any recommendations around men with breast cancer? Because as women, we may have brothers, sisters, cousins, uncles, husbands. What recommendation you have for them? Just even first step.
Right. So it's rare, and a lot of times there is a genetic component to men having breast cancer. And fortunately, it's usually not the aggressive type, but you still treat it the same way. I think the hard part about it, two things. One, it's not first on the list of things if a man has a palpable breast mass. So a lot of times these can take a while to be detected or diagnosed. So that's the one thing that we do need to kind of tell men that, we do have breasts and you can get breast cancer. So if you do feel something or notice something, first of all, get that taken care of and evaluated. And then the second step is imaging. How do you, because, men typically can't do mammograms. And so, it's a little bit more challenging because you have to do maybe more advanced imaging, such as an ultrasound or MRI or something like that. Those are the two things, but we still treat it the same way. There may be a little stigma because I had one guy who would make jokes and basically say that he was a female or something like that. And I just tell him that, look, this isn't a male, female type of thing. The only reason why it occurs more in women is because women have, bigger breasts, and so more chances of developing breast cancer. So, and also hormone, and so we just got to fight these stigmas that we do have. And as Deborah mentioned, a lot of times patients believe that they did something wrong or their family members to develop cancer, and I think that's just one of those things that we need to realize. Cancers can just occur to anybody at any given time. It really doesn't, select who it wants to affect. And so I think we just need to be more aware of ourselves and more aware of our bodies as well as each other. If you notice that your family member has, lost a lot of weight, notice bumps or things, going on, just be like, hey, I think something may be going on, once you get that checked out.
Thank you. Thank you.
I'm gonna add to that for the ladies. Everyone knows who Richard Roundtree is, correct?
Shaft.
He's Shaft. I mean, how strong of a male figure can we talk about? And he was diagnosed with breast cancer. And he found something that was unusual. So every time I've had male patients that they say something and I use Shaft, that changes their perception of, wow. But he is alive today and doing well because once he noticed, he followed up, right? Okay. So if nothing else too from this, if you notice it's different, follow it up, right? Because the manliest of man in Shaft, he will tell you he is a breast cancer survivor, right?
Yes,
and that was like 1993. Doing his physical, doing filming, I actually researched so much into that because him coming out was a precedence for men to understand there is breast tissue, and I will say this, the size of the breast does not determine breast cancer or not.
That is that's an excellent point because
we
have a misconception. You touched on something, survivorship. what does it mean to have a survivorship plan? And I'd love for both of you to talk about that.
I will give basically, once a patient is diagnosed with any cancer, they're a survivor. Okay, that is our true definition. Survivorship means that all treatment modalities are completed, and that is evaluated with the team, and it's a collaborative effort. So that means that the medical oncologist, the radiation oncologist, the breast surgeon are all in collaboration, that all treatments are completed, and that based on that treatment and outcome, there is no visible cancer noted. And survivorship from that point changes the frequency of follow-ups with a provider. And a care plan it can be formalized in the paper, and that is really the best practice, is a paper documentation that has from your very first diagnosis, meaning when you were diagnosed, each time you had any kind of radiation intervention, any treatment plan, and then it discusses what's the plan from this point. So when you're in a survivorship status, they're explaining that from this point on, you follow up with the medical oncologist every 3 months, with the radiation oncologist every 6 months, yearly, with the breast surgeon yearly. So you have a plan that says, not that cancer's gone and that's it. There's no detectable cancer, and from this point, we're going to evaluate you, and that evaluation will be adjusted to where they deem, is it necessary to continue a year? Is it necessary to say there's nothing that substantiates seeing from that point? So that is an individualized and a collaborative effort.
Thank you. Thank you. I'm not sure if Dr. Ray wanted to speak to that. I thank you for that response. There are, wow. Should one stay with a navigator? Well, I think you sort of laid it out in terms of what a survivorship plan is. Would a navigator be included as part of that post-treatment?
Yes, typically when a navigation is defined in different terms, and so a lot of facilities have survivorship navigators from that point. And so navigators are usually broken down between the active navigation, which is more frequent, as opposed to a survivorship navigator that is a touch point. Because once a woman has been diagnosed and spent 6 months to 2 years in active cancer treatment, and then we say to you, you're well, that's it. That is like detaching someone and saying, you were crawling, now run.
Mm-hmm.
Because in that year of active treatment, the majority of women are saying, what if it comes back? What if I need something? What if I need to just ask Dr. Ray, why is my skin tissue changed? Or why am I having more sensitivity in the sun? Or should I continue with these creams? And if Dr. Ray said, bye-bye, you're done, then the patient's like, again, that perception of all you wanted was the money and you didn't care, right? So Dr. Ray has it set up that, hey, you need to see me every year. And the lady will say, well, all he did was looked at my breast and said everything was good. He did more than that. He evaluated where should he be at? Where should this person be at? He evaluated for a plastic surgeon. The plastic surgeon might not do the last reconstructive surgery until Dr. Ray says the tissue is healthy. Because you can't do reconstructive surgery on tissue that has been radiated without it healed properly.
Thank you.
Yeah, I mean, so true. I mean, because, unfortunately, treating cancer can sometimes, we see it cause side effects, and it's one of the things that we do have to monitor. And then, I tell patients all the time, I want your visit to be boring. I want to not have any issues going on. These are the things that we hope for, and I know patients sometimes want, something to come out of it, but those to me are successful, treatments, where that we're not having any complaints or anything like that. And so that's what we want to see. You know, we want to see that patients are doing well and not having any significant side effects or issues or concerns. To me, that's a blessing, you know, because most of the time, you know, we're seeing patients who do develop symptoms or side effects or problems, and you know, and so it's good for us. And I understand, you know, you don't want to just show up and have an appointment when nothing's going on, but that's sometimes the best time, because at least from your provider standpoint, we enjoy those moments because we know that you're healthy, you're doing well. I mean, even though we treat cancers and, you know, we want to get rid of everything, it's good to see healthy patients. And, you know, when you start following up, sometimes we want to know if we did the job well, and you know, and just touch base again, you know. So it's just another way to kind of communicate. And again, just have a plan going forward with the primary care docs and, you know, and everybody else, as well as the team, to let them know how you're doing, because we want to know.
Dr. Ray, you just spoke to that vested interest that that you and Deborah have in your patients as well, because you want to see a healthy patient, and you know, and be able to address them as a healthy patient. So you're putting all your energies into getting them well. I'm glad that we ended on survivorship, because there are a lot of survivors I know in the chat room, and if you haven't already announced it and don't want to, that's fine. But some have already acknowledged I am a survivorship. So and thank God for that. And continue to share, if you will, share your story with other women. Cheryl is going to, if you wouldn't mind, share a poll that we'd like you as we continue finishing out. It is 13 after 10. We thank you and respect you for your time. And we're sorry that we had to, you know, we had a little technical difficulties, but we hope that we made up for it. This has been just an outstanding amount of, one woman said, just overwhelming information. And so I'd like to thank, before we hand it off to you for final words, and as Cheryl lifts the poll, we would like to, you know, just to reiterate to women the importance of sharing information, bringing your book with you to your appointment, having a conversation with your general practitioner, being as honest as you possibly can, being honest with your general practitioner, follow up on your recommendations. When you're asked to get your mammogram, get them on time and ask questions. What other recommendations of screenings do I need? Ask questions and come prepared. Come prepared for every appointment. So, Cheryl, is the poll, has it been?
The poll is up and the responses are coming in.
Oh, great. That's great. So I would like to know, Dr. Ray and oncology nurse navigator, Deborah Runnels, any final words for our group here?
I want to add that I do appreciate Dr. Ray being on board and participating. And I want every person involved on this to understand that he is a male, and he is very adamant and very, and I looked you up, Dr. Ray, believe me, I researched, right? And but very complimentary feedback. And we have to understand as women, sometimes we're uncomfortable going to a male, but understand his expertise is what helps with the process. And if nothing else today, I say this to every woman: when school starts, every child is sent, especially football and sports, they get their complete physical, they get in, you take off work. If nothing else, make sure when your child is getting their yearly exam, or your grandchild and you take them, make an appointment for yourself to do the same thing that month. If you do that, you will keep yourself in line. And that means not just breasts, with dentists, with seeing someone to get eyes checked. If you have a pair of eyeglasses and they're 10 years old and you're using the same ones, and I'm wearing glasses, so I'm not, that means that you need to get a new prescription, right? So just know that every part of your health is important. You've got to take time out to put that importance out there. You're just shaking your head at me, Dr. Ray.
No,
My patients and everybody knows me.
No, I can't add anything else. I mean, you basically nailed on the head. All I can say is I concur.
Thank you, and thank you all. You know, we asked the question at the top of the call: what does breast health, by any means necessary, mean to you? It says, some women say self-care, especially related to our breasts, hormones, reproductive organs. Breast milk is often the first source of nutrients. Breast health, by any means necessary, is ensuring that we as women are knowledgeable about breast care, including breast cancer information. 34 years free of breast cancer demonstrates the need to check your breast as directed. As at 38 years old, the last thing I thought about was having breast cancer. My diagnosis impacted the lives of many other ladies who never had a mammogram, including my mother and grandmother, taking care of your breast health. So I you know, just feel I am overwhelmed with gratitude for our guest speakers, Dr. Jeffrey Ray, and look him up, and and oncology nurse navigator Deborah Rundles. Look her up. I know she also has a she's on Facebook. Uplift, add Uplift Sisterhood, and sister is SYSTER. Hood, HOOD, if you just want to be in conversation. And am I missing anything? And Dr. Ray is also on LinkedIn. They both are on LinkedIn. And so please just look them up and just be engaged with what they're doing, the discussions they may be having with others. So with that, Cheryl, we have the poll that is completed.
We do. The poll is completed. I can take it down. But thank you so much for your responses. Your responses to the poll always help us.
Thank you. They do. And so we've already said our thank you. We would like to bid you adieu, and to have a wonderful Saturday and weekend. You see here, this is our contact information, and you'll be receiving additional information. We have we'll be sharing with you a PDF with some of the resources that you can use just to follow up. And am I missing anything, Cheryl?
No, just here's to breast health.
Cheers to breast health. Thank you. Cheers. Thank you.
Cheers.
Thank you, everyone.
Thank you.
Thank you, Dr. Ray.
Thank you.
Oncology nurse navigator, Rundles. Thank you.
Thank you.
You're welcome.